All right, thank you very much. Thank you for the opportunity to address you sort of in this matter. I think in terms of clinical medicine, genetics have been something that's been in the lab and has been a little bit sort of airy-fairy, and especially for clinicians, it's something that we haven't had any training in genetics as undergraduate students. The training was very sparse, and even in postgraduate training you had very little information about genetics and the way that it impacted on your clinical management of your patients. And I think that the whole role is changing a lot as we're going on, and I think certainly in my practice I'm seeing lots and lots of patients. We're using genetics more and more, and patients are becoming more aware, so they are coming to you to ask you about how to manage their risk. So my topic is really in terms of breast cancer, but just we have seen a gradual worsening in the numbers of cancer patients that we're seeing, and part of that has to do with the fact that we are living to an older age. I always say, from birth to death you have a life that's just filled with uncertainties, and it ends with the certainty of death. So that's really the only certainty we have in life. And part of that is, as you get older, genetic uncertainties also creep into your life. And you have little mutations that are taking place. No one can predict that exactly. And we're only sort of starting to scratch the surface as to how that affects the way we deal. Now, obviously, things like patients surviving cancer longer, being able to have children after they've had cancer, environmental factors, things like smoking has been sort of the model for environmental factors causing cancer over the years. And we know that you have a sort of a 30-year lag from the time someone starts smoking until they develop their cancer. We see there's about a 30-year lag in that. We know that in the 60s, with women emancipation coming along, lots of women started working, they would have children later, they would have less children, and all of a sudden they would also start smoking. So we saw a huge increase in the amount of women that were smoking since the 1960-65. So in reality we're seeing the start of that epidemic taking place now. And we can expect a huge epidemic of female cancers in the next couple of years. And our efforts to stop smoking now, for example, will only give us results in about 20 to 30 years' time. So this is really the impact we're seeing. All of these things are interlinked, but in principle I always say that we need to remember, in the old days they used to think cancer is an infection. We give an antibiotic, it kills the bugs, patient's fine. Okay. Cancer is not an infection. Cancer is a genetic disease. Cancer cells are in essence very, very efficient versions of our own cells. They are cells that have become rebellious to the normal control mechanisms, and they grow, but they in fact are cells that are very efficient. We've got cancer cells growing in petri dishes that are 80 years old, and their youthfulness, if you look at their molecular structure, is the same as when they started 80 years ago. Whereas our own normal cells get older, their potential to recreate becomes weaker, but cancer cells don't do that. They stay young and they retain their ability to grow and to repair themselves. And that's what make cancer such a tremendous problem for us to deal with. So things like chemotherapy, if you compare that, they came from the era of us thinking it's an infection. We give you some sort of toxic substance that will kill the germs, you'll be fine. But we've reached the plateau of what we can gain with chemotherapy, really. That's old medicine. Now we have to look at different targets to treat these patients. So the genetics in cancers are very simple. It's basically a matter of the guy with a go board, is not dropping his hand, so it's just saying, listen, let's make more cells, and the guy with the stop board has fallen asleep. Okay, and that's basically what happens to a cancer cell. It keeps on replicating, and there's nothing to stop that process from going on. So in my practice, in the world out there, patients really have two concerns. Number one is, am I going to get cancer? And yes, your chance is about 1 in 3 of getting cancer, if all else is equal, but that is the concern most patients will have. And number two is, when you get cancer, the question is, am I going to die from this cancer? Will I be able to survive this cancer? And we want to try, in my lecture today, we want to address, I think, really those two questions. So our attempts to try and find out, is someone going to get cancer? Really, in the 1991, they published the first data to say we've got a gene that predicts or predisposes the patients to get breast cancer. That was the BRCA1 gene. It's situated on the chromosome 17, and that was a huge breakthrough. We thought, this is just a matter of a bit of time, then we're going to be finding all the genes that are causing cancer, and we're going to be able to deal with breast cancer. So it wasn't, 3 years later that they found the BRCA2 gene on chromosome 13. And in essence, the BRCA genes are both tumor suppressor genes. So the little guy with the stop sign. Okay. And when they don't work, when they sort of have the stop sign halfway up or whatever, then that's when the problems start happening. So unfortunately, we're only seeing BRCA positive patients in about 5 to 10% of our breast cancer patients. So we still have 95% of patients that come to us that says, well, doctor, I've got no one in my family who's had breast cancer. That's the reality of our practice still in South Africa. So we're only scratching the surface with these two things. So unfortunately, in most patients, I cannot tell someone whether they're going to get breast cancer or not. But I also don't want to miss these patients where I can potentially intervene before they get breast cancer. Just sort of a quick background is that when you inherit one copy of a gene from the mother and one from the father, and under normal circumstances you would have 2 copies of the same gene on each arm of the chromosome, and they would be equally willing to do their job. If you have a mutated gene, then usually this one will take over the function, and it will make sure that the function continues. But the problem is, in cancer, now we know from research that you need to have a minimum of 4 mutations to be able to make a cancer cell. And this can be replicated in the lab quite easily. So from a normal cell, you need to have 4 sequential mutations to be able to have a malignant cell that will cause cancer. If you get born with a mutation already, you sort of one log down that route. Okay, so obviously someone still needs another 2 mutations to be able to get to the point of developing cancer, but they sort of a quarter down the way already. And that's why patients who then inherit a single defective BRCA gene from mom or dad will inevitably have a higher risk of developing cancer, because these are the type of mutations that happen with life. With smoking, with having children too late, with, all stresses of life, those type of things. So just that you understand, the BRCA gene in itself doesn't cause cancer, but it puts the patient on a path of already being prone to developing cancer. So we have 4 levels that we can test patients for to see whether they have got a problem with a gene. And there's a lot of uncertainty in genetic testing in this realm. So first off, obviously, are the founder genes. These were the ones that we originally found. We saw, here's a bunch of Dutch people coming to the Cape. They stayed in a relatively close proximity. They undermarried, and so now we have these sort of 4 genes that are replicated in the generations to go on, and they're fairly easy to test for. We've got probes that we can check for, easy to test. But the reality is they make up a very small percentage of the patients that we see. If you're living in an environment where you're dealing with these families, it can be that that 10 to 12% of the members of those families will have the gene. So it becomes quite a high risk. But once you get outside of that, if we enter sort of the traditional African field, we're looking at black South African patients, even mixed race South African patients, we're seeing a lot less of these mutations. And our pickup rate really becomes maybe 1 or 2%. So these are easy to do, but in an environment where you're not really dealing with that homogeneous type of population, it really doesn't help you that much. The same with the Ashkenazi Jews. We've got 3 very specific mutations. If you're dealing with that type of population, sure, you can test for that. But in reality, the average patient that comes to me has a very mixed background in terms of genetics, so we can't just rely on this. So exon 11 carries about 60% of the relevant mutations. So you can just sequence that part of the gene to see and pick up some additional mutations. And if you do the founder genes with exon 11, you'll pick up about 60% of the relevant mutations that would cause disease in the patient. But in reality, most patients would actually need to have full sequencing of the gene. This is a laborious process. There are lots of technical aspects. The labs differ a lot in terms of their quality control, and you have to select your lab to do these type of testings very, very carefully. The next level is to check for deletions and insertions, and there are even fewer labs that actually check for that. And these are difficult things. If you just do normal sequencing, you're going to miss these. There are commercially available tests, but again, it takes quite a bit of effort from a lab to set them up so that they can really do the full level of testing. So the labs I use, I always make sure that we can actually get all of that information, because I don't want to send the patient away and say, well, you haven't got a gene, and then in fact they do, but we've actually just missed it, because then we've really wasted a lot of money and caused a lot of anxiety in that family. Alright, so the challenges we have with BRCA testing is that we have a huge amount of mutations that have been described. So there are more than just under 2,000 mutations that have been registered as being notable mutations in the BRCA gene. So there are quite a lot of mutations. Most of those will occur in 1 or 2 families only. So it's very difficult then to really know what the natural history will be of that specific mutation. We don't have huge numbers on most of these things. So the problem really is that, remember, a gene codes for a specific protein. We do not have a method of testing this BRCA protein, and we specifically don't have a way of checking whether that protein is functional or not. So you might in fact have a mutation that does code for a protein, but that protein's 3-dimensional structure is different, so that protein doesn't do its job. So the ideal would be in future, if someone wants to attack a new research project, is to try and see, well, can we maybe isolate this BRCA protein and test its functionality in some way, that we can say this protein is 90% or 60% or 50% functional, because that will in the end determine whether the patient develops cancer or not. So this is the dilemma we have. So a lot of these mutations, we actually don't know what the result of that mutation would be on the protein that it actually produces. It's easy if we have large deletions and things like that, because we know that the protein is truncated. It's a non-functional protein, but we have about 15% of patients we have mutations that we really don't know what the risk of those mutations would be. Now, and the problem with those mutations really is in terms of our counseling of the patient, because I need to tell the patient because of your result, what is going to be the risk of you developing breast cancer. And this is really where the difficult part comes in. And that's why I say the ideal would have been if we could test the functionality of that protein to see whether that protein actually is doing its job or not. Now, there are a couple of things that we need to realize with BRCA testing. The genotype, in other words, the patient would have a certain mutation and would influence the phenotype, in other words, the function and the form of that protein. And that is the unknown factor that we have, or that we don't have. And I'll show you a table now. That's why we have such huge variation in terms of risk of whether the patient has, of what the patient has for developing cancer. All right. And we know that certain patients in certain families, for example, will have a much higher propensity to develop ovarian cancer versus others, in spite of the fact that they have the same mutation. So the genotype and the phenotype are different, or the phenotype is different in terms of that patient. The same with the penetrance. So you might have one family where all of them develop breast cancer in their 20s or 30s, and then you would have another family where the patients only develop their cancers in their 70s or 80s. So difficult to predict when are you going to develop your breast cancer, because I need to do some prophylactic measure before you get to that point. Okay. So I need to move on a little bit. So you can see on this table that there are huge variations in risk for patients, and that really depends on the type of mutation they have, the phenotype of that mutation, and the penetrance of that mutation. All right. And especially in ovarian cancer, you'll see that there are really big variations in the different ones. Especially in this BRCA2 group, we're actually seeing some families where there's quite a high risk for ovarian cancer. I have one family where, in fact, there are more ovarian cancers than breast cancers with BRCA2 mutations. So the penetrance is a lot different. So it makes it difficult for us to really estimate what the patient's risk is. One new thing, I think it's relatively new, that are coming along is the whole issue of anticipation. In other words, that you're seeing generation 1, the people develop breast cancer at 60. Generation 2, they developed it at 50. Generation 3, they're developing it at 40. So we've got two recent publications that have both looked at this. The one showed a 7, almost 8-year decrease from one generation to the other in terms of age of developing the cancer, and the second one was almost 12 years in BRCA2 patients. So this changes my way of dealing with these patients and saying, well, instead of saying you should have your surgery at 35 or 30 or whatever, I now need to look at when are your family members developing their cancers, and I need to look at somewhere between sort of 8 and 12 years before that for me to do your surgery. All right. I'm not going to. The concept in the latter study, they actually found the patients were developing telomeres. Telomeres are the things that make the cells youthful in a certain sense, and that's why we started seeing they were losing telomeres off the gene. So now the patients were developing that cancer earlier and earlier and earlier in their life. All right. So we know that it's very prominent in the media with Angelina Jolie. I think there is a talk about that. I'm not going to really talk too much about who should be tested. It is in my slide, and I think this will be available on the website. But I think the important thing would be to say these patients really need to be counseled by people that are knowledgeable about all these factors in terms of BRCA testing, in terms of what types of surgery and what types of prophylactic measures we need to offer these patients and when to do so. I see lots of patients coming from gynecologists who wants to do hysterectomies left, right, and center. We always say that if the only thing you have is a hammer, then everything looks like a nail, and this is a little bit of that same type of problem. So patients with BRCA mutations do not need to have hysterectomies. They need to have a proper ovarectomy, BSO, the tube, the peritoneum needs to be taken out. So these are difficult matters that we need to try and sort of train and increase awareness for the patients. All right. I want to get to the latter part. I'm running a little bit behind. It's the whole issue of genetic profiling in breast cancer. So we know in the old days we used to say, well, we look at tumor size, we look at the nose, and we decide, well, you have sort of a risk of this much, so we'll give you chemotherapy. And again, the other thing that comes to mind, is a fool with a tool is still a fool. So we didn't have anything else. We didn't know better, so we just gave them what we had. All right. But now we're seeing, we're actually not doing very well. We're really helping about 10% of patients. So we need to try and sort out which patients would possibly do better. So the idea was to say, well, cancer is a genetic disease. We need to find out which patients have a specific genetic profile that makes them at risk for developing metastases. And that's where the whole concept came along in 2001 and 2002. From the Dutch group came the first papers to say that they've got a gene profile that can actually accurately predict patients who are going to develop metastatic disease. And it's been 11 years since they developed that. 5 years later, another group from America came out with a 21 gene profile that sort of said, well, we have sort of a similar profile that can do that. And since then it's just been like a hectic market of people, and I think sometimes the advertising and the commercial part of it was sort of going in front of the scientific part of it. So we need to really be careful about this. The original papers came out using microarray technology, and I think in principle microarray is something that is really a very reproducible, very stable platform that can be used in multiple labs and give similar results, whereas the RT-PCR that was used has a lot more quality control issues, a lot more problems with reproducibility and things like that. So different techniques were developed, and I mean these are just two of the sort of main commercial products available. There are several others. I'll show you a study where we've actually looked at that. So I think the issue was to say, well, we've got something that we can actually predict better than just looking at the outside features of the tumor. So I think the main benefit that also came along, we knew that there were different molecular subtypes in the cancer groups, but we were finding it difficult to really decide, you know, what type of tumor do you have. And with the genetic features coming out, they added 10 genes to that 70 genes, and they found, okay, now we can accurately predict what type of molecular cancer the patient has. And this has a lot to do with the patient's prognosis, and also it has a lot to do with what type of treatment we'll give the patient. So that was a very, very important breakthrough in terms of management. But I think just to give you an idea, you know, with chemotherapy trials, we often see lines sort of just splitting there, and there's maybe like, you know, you can just get a credit card in there, you know, and we would be very excited because we had an additional 3% benefit for the patient. But this is the predictive value on 10 years in a patient who has a poor risk genetic profile versus a patient who has a low risk genetic profile. So yes, there are still some of those patients that die. All of us have to die of something. A lot of them died of other things than cancer. But these patients were the ones that showed really, I mean, there's a significant risk of dying if you have a high risk genetic profile. So firstly, the predictive value of it became, or the prognostic value became very, very high. Predictive role came in as a big question, because now the question is, all right, that's good and well to say, well, congratulations, you are going to die of your cancer. We can't do anything about that, you know. Versus saying, well, you're a high-risk patient. We know if we give you this treatment, it is actually going to benefit you quite a bit. Versus someone who has a low risk, and we don't have to give you that type of treatment. And this is really where predictive roles come in. We are still waiting on big studies. We've got a few small studies that have looked at this. A lot of these studies took historic cohorts, prospectively collected samples, and because they were frozen, we could actually test their genetics and see what type of profiles they were doing, and we could compare those patients 10 years down the line. So we can almost call that a retrospective, prospective trial, because it's not quite the same as me going back in the records at Tygerberg and looking at how many patients we've seen, looking at clinical details, which is sparse. We're now looking at genetic details, which is accurate, and we're looking at a prospectively accumulated cohort of patients. So this allowed us to actually show, well, at least both of these are showing some signs that we can actually predict the patients that will respond to systemic therapy well. Okay, and that was a major step forward. Now, they are busy with prospective trials, but the only sort of recent prospective trial that became available was the RASA study, and they were looking at this as AOL is adjuvant online. That is what we normally use to just look at the tumor size and the nodes and things like that. And we would say, well, if you have a risk of dying in 10 years of more than 10%, we think you're high risk. So those would be those two. And if you have a risk of less than 10%, we would think that you were low risk. We know some of them will still die of their cancer, but it's not worthwhile giving them chemotherapy. I think the main thing came in to say that patients who had a gene profile in those two groups, those groups, or this group of patients would have had chemotherapy. And because they were found to be low risk, almost half of the patients did not have to have chemotherapy. because they were not going to respond, or they were not going to have major benefit from that. And if we look at the disease-free figures, we can see that this group of patients who had a low-risk MammaPrint profile has a significantly better 5-year survival, in spite of the fact that only 44% of them had systemic therapy, versus this group, which had a high-risk profile. 97% of them had chemotherapy, and in spite of that, their prognosis was still significantly poorer. So it showed us that we could at least potentially omit chemotherapy for these patients and still have a very good survival rate. There were several neoadjuvant trials that were done. Neoadjuvant trials were sort of easy to do because you had a big tumor. You wanted to shrink that tumor before you would operate them, so you would give the patients chemotherapy. So it's easy to do. In 6 months' time, I can see did the tumor die completely or didn't it. So it's not a difficult trial to do, and it gives us a good idea of whether that cancer will respond to chemotherapy. So here we have 167 patients. 23 had a good signature. 144 had a bad signature. Now remember, these are patients with big ulcerating tumors. They've got bulky matted nodes in the axilla. Patients who actually are unfit for surgery, and patients who would normally have a survival or a risk of death of about 70 or 80%. So we found in the good risk patients that none of them, after having chemotherapy, the tumor went away completely. So all of them had still had some tumor left behind, and in 2 patients the breast tumor had shrunk away, but the nodes under the arm stayed behind. But in the bad risk group of patients, we saw that 20% of the patient, the cancer in the breast and the nodes went away completely. And in the breast, another 37%. So the response to chemotherapy for this group, so this signature predicts the chance of that chemotherapy killing the cancer a lot more effectively than patients who have a poor profile. We had almost no response in those patients. All right. So unfortunately, I said life is a series of uncertainties until you get to the final certainty of death. So yes, we have lots of uncertainties. The trials are mixed between big and small tumors, node positive, node negative. But the reality is we have got some good data that we can already start to use. Okay. Cost is a major issue. I mean, Oncotype is charged in US dollars, so if we do poorly like now, it's costing you sort of 35,000 Rand to do the test. MammaPrint is giving us a fixed rate in South African rands at least, so the past 3 or 4 years it's remained the same in spite of the fact that the euro has gotten stronger. So, but still, it's an expensive test. But if you can save money on chemotherapy, you're easily going to actually make up that amount. Here's a table that compared all the currently available genetic profiling tests. Just go back there, yes. So here we have a lot of molecular tests that they've done, okay? And the only thing I actually want to show you here is that there's about a 30% disagreement between them, which is a bit of an issue. So it means not all of them are accurate, and it also means, or the question is then, okay, which ones are? So in this specific study, they actually found that the 70 gene profile was the most consistent in terms of its performance. So, but as I can say, everyone wants to jump on the bandwagon, and it's becoming quite difficult to decide which is which. So all of these are the reasons why I think we've selected to use this specific test in South Africa, because it seems to be performing consistently well. All right. So since 2007, we've been using MammaPrint. Initially, we had to send fresh tissue, but later on, we were able to send the formalin fixed tissue, which really made a huge difference in terms of our yield. And we've had 118 patients from South Africa that we've done MammaPrint on. Okay, and we've made a decision that we are not really worried about those patients that are HER2 positive, and those are patients that really requires chemotherapy. Really, almost doesn't matter what. The estrogen positive patients are the ones that are the most at risk, and they need to be HER2 negative. And we were selecting tumors that were bigger than 1 centimeter, and we were selecting patients who had less than 4 lymph nodes in their axilla. And if you take that, now this is the group of patients that potentially will have chemotherapy unnecessarily. So looking at that group, we found that in fact 60% of those patients were good low-risk patients. So they would not respond to chemotherapy, even if you gave them chemotherapy. You would have no or very little benefit. Versus 40% of patients that were high-risk patients that we saw, right, if we gave them chemotherapy, we are going to have a 20-25% benefit in chemo versus the 10 or 15% that we would have if we'd given chemotherapy to the whole group. So in our current data, it seems that we can save about 60% of the patients in that group from having chemotherapy, which obviously cost-saving wise is a huge issue. We've had 4 patients who's had BRCA mutations. BRCA mutations, there's a lot of differences in opinion, but in reality we don't have good evidence to say that they do worse than other patients. But we've had 4 patients. 2 of the patients had a BRCA1 mutation, 1 had a BRCA2 mutation, and all 3 of those patients turned out to have high-risk profiles. So I don't know, it's early days, but we might be seeing a trend there. We had 1 mutation of unknown significance, one of that 10 to 15% of mutations that we really don't know what the result of it will be, and that patient turned out to be low risk. So we'll have to watch this space and see what happens in future, whether we can use the MammaPrint in deciding what the relevance of that mutation might be for the patient. All right. So we want to know, we always want to have prospectively data. The MINDAC trial has been going for almost 8 years, and we're really expecting data on that in the next year or 2 that will really tell us whether those patients will do a lot better or not. But in the interim, while we're waiting for those results, I think we have to fall back on the data that we have, and there are at least 14 trials that have shown that MammaPrint will have a good predictive value in whether you should use chemotherapy or not. So the question is, should we be using it at the moment? My answer is yes. I think there's enough data to support the use of it. I think we can really save lots of money if we do that. But I would say we need to be careful in what tumors we are using it on. So I wouldn't do tumors under 10 millimeters. Really, we would be looking at patients with stage 2 or stage 3 disease, and if we use that to reduce our chemotherapy impact on the patients, we would, I think, do well. I think it is important to be careful when you look at the results of these studies. This is just one sample of a patient, and this is really just, it gives you a result to say, well, okay, you're a high-risk patient. That's very important to know, obviously. It confirms my estrogen status, which is very important, and it confirms my HER2 negative status. And that is what we really want to check. And so far, we have had 100% correlation between our post-operative values that we got in our local lab and the MammaPrint values. So this patient would then be considered a high-risk luminal type. So he's the type of patient that would potentially gain benefit from chemotherapy. But now they give you a little figure like that, which someone would say, oh my goodness, you've got a 29% risk of dying of your cancer. And this is not true for this patient specifically. This is true for the group of patients that they tested in those 2 trials. And that was a mixed group of patients. So in reality, that 30% means, all right, if you had the same tumor, good risk tumor, your risk would be 30% more because it's a high-risk tumor. And we can reduce that 30% risk by about 25% by adding chemotherapy, and by another 50% by adding hormonal therapy to your treatment. So I think it's important to just warn people against the fact that you shouldn't use that as to saying, you, Mrs. X, have got a 30% chance of dying of your cancer. That her risk might in fact be 70% if she had a big T3 tumor. Or a risk might in fact be only 8% if she had an 8 millimeter tumor. So we had one patient where there was an error from the lab. They reported it as a big tumor. We sent it away, and then afterwards they said, wait a minute, we actually had a look back, and the tumor is actually only 8 millimeters in size. So we had one patient where this almost happened because of an error in our local lab's reporting. But I think that's important to just realize. So the interpretation of MammaPrint is not something I think one should really know the literature, know the data before you start embarking on that type of thing. All right. Sorry for maybe a few minutes over time. So any questions that you might have? Yes.
Judging by the fact that Panorama is a private hospital, what percentage of your mamma patients actually submit to MammaPrint, and when you can use this predictive algorithm to spare the patient the chemotherapy or advise him to have chemotherapy?
Okay. In principle, about 85 to 90% of patients will fall into that category of having a estrogen positive tumor. So cost is the major issue now. So even in our practice, most of the medical aids are not covering the cost. They just completely, how shall I say, they have no knowledge of it and they don't understand it, so they just say we don't cover it. So there are very few patients that can cover 25,000 Rand out of pocket. So of the patients I offer it to that are financially able to do that, in that selected group, most of the patients will take that. So yeah, I think cost is still the major issue for us at this stage.
Isn't the fact that the chemotherapy itself is very expensive an argument for the medical aid to submit to this testing?
One would think so, yes. But I don't know, you need to have a brain to decide to realize that. I think the issue is, it's a long problem to change the course of a ship is a very slow process. So we have some medical aids that are covering that. I think for me the main thing is to say, all right, if I were a medical aid, decision maker, I would say, I will force all patients in that group to have a MammaPrint, and you may not have chemotherapy unless you can motivate otherwise, and then you can save chemotherapy in 60% of all your patients. At the moment, because there are few units doing it and we have a few patients, it's difficult to really show that cost benefit. So we had a medical economic study that was done by one of the medical aids, and they were quite excited about that, and they actually advised them that it should be available to their higher tier plans.
It's just a clarifying question. Thank you for a wonderful presentation. If I understood you correctly, what I heard you say was that if you have a low-risk MammaPrint, in other words, a favorable profile, and it's an operable tumor, chemo is not necessary, and if it's an inoperable tumor, chemo is still ineffective. Whereas if it's a high-risk patient, whether it's operable or inoperable, chemo is effective. Is that correct?
Firstly, in operable patients, it has a high chance of causing the tumor to shrink significantly, making it operable, and it will inevitably have a 25% reduction in the patient's chance of dying of their cancer. Whereas in the low-risk profile, you would have none of those benefits. Obviously, because they're estrogen-positive tumors, we will give all these patients anti-estrogen treatment, which will give them a 50% benefit on its own. So the main question is whether they should have chemo in addition to the anti-estrogen therapy. So it's not like we're not treating them at all, we're just treating them appropriately.
Is die probleem nie eintlik die 40% wat 'n voordeel tog uit chemo sou kry nie? Solank mens nie daai nog kleiner kry nie, is dit nie daai paar pasiënte, die 40% is miskien waarop chemoterapeute te konsentreer, hè? Nie die 60% wat dit nie nodig gehad het nie, maar die 40% wat dit.
Yeah, I think if I understand this correctly, the ideal is to then say, all right, you are one of those 40% of patients, you need to have chemotherapy. If we just use our clinical decision-making tools, Adjuvant Online, for example, it gives you 100 patients that says you have a risk of X, So you have to give chemo to all of those patients to have benefit for maybe 10% of them. Now we're taking that 100 patients, we're saying this 60% of them don't have to have chemo. We're ending up with 40% of patients and we're having a benefit of 25%. So this is the way of selecting that 40% that you need to give chemo to. We don't have a tool except for MammaPrint that can do that. All the other tools will still end up with 100 patients that has a very low risk benefit for the chemo. Ek hoop dit verantwoord jou vraag.